Your final lecture is there.
There's a microphone. Okay. Good. Well, thank you so much for the kind introduction, Milena, and it's a pleasure to be here. This is my first visit to Serbia, in fact, and it should have happened a lot sooner, but apologies for not showing up sooner, but I hope I'll make up for it now. I'm going to talk about unconventional approaches to the treatment of cancer, because there's an old saying that says, if you do what you did, you get what you got. That's logical. So innovation in cancer care needs to come from innovation in the lab, right? So we need to think of fundamentally different approaches in the lab to come up with fundamentally different treatment regimens that can be used in the clinic. And I'm also the person that will not rest until I found a clinician that is willing to test whatever I've cooked up in the lab in the clinic, which makes that currently we are at 16 trials that run at my institute at hospital, affiliated hospital, and we are looking to start another 4 in the next 12 months. So you see that we are very active in translating knowledge to proof of concept clinical trials, and there's nothing more rewarding. Made by 2 small companies that I interact with, Lixi and Epigenics, and they are instrumental to what I have to say. So we all know that cancer is a disease that basically kills because we get drug resistance. And we also know that the answer to drug resistance is combination treatments. We know that from bacterial infections, we know that from HIV. HIV was a deadly disease, it is now a chronic disease because we mixed 3 drugs that have non-overlapping targets and non-overlapping resistance mechanisms, and therefore you cannot get a virus that is resistant to all 3 drugs at the same time. So, the answer to cancer, my friends, is simple. It is combination treatments, right? So why are we still not curing cancer? The answer is simple, that we have an awful lot of possibilities to combine drugs, and combinations also tend to become toxic, so not all combinations are workable in practice. Now this whole notion that we need to fight cancer drug resistance by combination is not new at all. This paper from 1958 already combined 2 regimens to treat leukemia, so we knew already in 58 that it had to come from combinations. And that problem has become really a lot worse, because with 1,000 cancer drugs, you can make 500,000 2-way combinations. And for HIV, we know that the answer is probably a 3-way combination. So the number is astronomical. So how do we help in the lab to select the most likely combinations of these many possible combinations that are successful? And we started this project around in 2011 in my lab, when I heard that while BRAF and melanoma patients were very responsive to the BRAF inhibitor, it turned out that the BRAF and colon cancer patients were unresponsive. And that was very surprising, because we all thought that if you inhibit an oncogene that is a driver of the process, you should get a therapeutic response. And in colorectal cancer, that didn't seem to be the case. So we did what we call a synthetic lethality genetic screen, in which we systematically inactivated all the kinases in BRAF colorectal cancer cells, and we asked simple question: which other kinase do we need to inhibit besides BRAF for the cells to die? And the answer was, we need to co-inhibit EGFR. So it turns out that if you inhibit BRAF and EGFR at the same time, now the colorectal cancer cells respond. And the reason that the melanoma cell doesn't have that problem is that the melanoma is not from the ectodermal lineage and therefore doesn't express EGFR, so it doesn't have the problem. So the moment you express EGFR, you have a problem, and we know that because melanoma cells that become resistant to BRAF inhibitors sometimes begin to express EGFR, and then you're resistant because then it behaves like colorectal cancer. So this was due to our close proximity to a phase 1 unit. We had the first patients on trial within 8 months post-publication. We saw the first responses. That led to a phase 3 study, and that led to a DMA and FDA approval of this particular combination. So here you see this path from preclinical discovery to clinical implementation, taking 8 years. Clinicians tell me this is fast. I say this is unacceptably slow, but the truth is probably somewhere in the middle. So after this initial success, we became very excited and said, now we're going to crack a much bigger nut.
And that was the bigger nut, was the notion that once you have a KRAS mutant cancer, that you should respond to an inhibitor downstream in the signaling cascade. And that one of the first drugs that became available in this cascade were MEK inhibitors. But then we found out in clinical studies that KRAS mutant lung cancer patients didn't derive any benefit from MEK inhibition, which was again surprising and again suggested there is such a feedback mechanism that reactivates the pathway when you inhibit MEK. So I want to talk about a way to solve this problem of non-responsiveness to MEK inhibitors and other MAP kinase pathway inhibitors. And I want to introduce to you what I call the new kid on the block. This is a kinase that you probably haven't heard from, called MAP2K4, also known as NKI. Now, my lab showed in 2018 that if you knock out MAP2K4 in KRAS mutant lung cancer cells, that the parental cells are very much insensitive to the MEK inhibitor trametinib or the ERK inhibitor, but now that you knock out MAP2K4, they become exquisitely sensitive. So that was really interesting, but mostly of academic interest because there was no MAP2K4 small molecule inhibitor, so everybody said, nice, interesting, but not very helpful because we don't have a drug combination to make this happen. Now, we've figured out how it works mechanistically. Here you see the two of the major signaling cascades that are downstream of receptor tyrosine kinase, the conventional MAP kinase pathway, KRAS, MAP, MAP, ERK, and then you have the MAP3K1, MAP2K4 junction pathway. And these two pathways are interconnected through a dual specific phosphatase called DUS4 that normally inhibits the signaling through junction so that there's only one signal at the same time coming through. The moment you inhibit MAP kinase signaling with a drug like a MEK inhibitor trametinib, you inhibit MAP ERK signaling, the DUS4 protein goes away, and now the jump-June pathway becomes active because the DUS4 no longer inhibits jump and June now activates a number of receptor tyrosine kinases that reactivates this pathway to the extent that the trametinib by itself can no longer block this pathway, and you get persistent signaling leading to survival. And that explains why if you knock out MAP2K4 and thereby inhibit this signal from MAP2K4 now jump and June, that the feedback loop is in fact interrupted, and that that trametinib and the MEK or the ERK inhibitor alone is sufficient because the feedback reactivation no longer occurs. Okay, so that was the explanation for what we saw here. So then a few years go by, and I come across a paper from a colleague, Lars Sender, who worked with Stefan Laufer, to make a small molecule MAP2K4 inhibitor, also known as NKI4, because Lars Sender had identified MAP2K4 as a critical factor in liver regeneration, and he's a liver doctor, and he figured that a small molecule MAP2K4 inhibitor would accelerate liver regeneration. And that is now why this company is called Heparigenics, liver regeneration. They want to, and they are in phase 2 trials with their small molecule MAP2K4 inhibitor to see whether it accelerates liver regeneration. But I wrote to Lars and said, Lars, we have a bigger fish to fry. There is a potential to use your drug also in oncology. So Lars sent me his compound called HRX233, and you see here again an experiment where we titrate in one direction the compound HRX233 in a increasing concentration, in the other direction trametinib in KRAS mutant cells, and you see that trametinib alone doesn't do a lot, HRX alone doesn't do a lot, the combination suddenly becomes highly potent. And then you can identify that in a sort of list that is present, is being developed for a different indication, and say, hey, can we use this in oncology? And I hope I have convinced the company to now set up an oncology division to bring this to the cancer clinic. And what I'm going to talk about to you now is completely ridiculous, to be quite honest. What I want to talk about is an idea that was so crazy that when my postdoc Matthias and Ruben came to me, even I was reluctant to embrace it, and I'm pretty tolerant to crazy ideas on average. So Matthias came to my lab and said,
René, I want to study hyperactivation of oncogenic signaling as a cancer treatment strategy. Rather than inhibition, he said we need to activate the cancer signal further. And his rationale was as follows. So if you look at the hallmarks of cancer, you see on the top side of the hallmark, you see all these properties that cancer cells gain when they get oncogenic driver mutations, right? Limited proliferation, independence of growth factors, insensitive to anti-proliferative signals. But on the flip side of that, you see that there's all the stress responses that the cancer cells must endure when they get these aberrant oncogenic signaling, be they damage stress, oxidative stress, mitotic stress, metabolic stress. So a cancer cell needs to balance this oncogenic signal that is good for its oncogenic properties, but is bad in the sense that it activates stress responses. And that makes for a very important conclusion, namely that tumor genesis shapes cells towards the right, or the optimal, but not necessarily the highest level of oncogenic signaling activity. Because if the signal becomes stronger, then these stress responses could become dominant. There's a fairy tale about Goldilocks where it needs to be just right, not too little, not too much, just right. And cancer cells know exactly what the right level of oncogenic signaling is, where the stress responses don't dominate over the gain of proliferative capacity. So that was, to me, a very important insight. And then Matthias said, okay, so if we inhibit oncogenic signaling, we know what we get. The tumors get a secondary mutation when the signal comes back in the presence of the inhibitor, so we need to do it differently. What we need to do is hyperactivate the oncogenic signaling. This will stress the hell out of the cells, the stress responses will be activated, and then we perturb the stress responses, and then the bastards will die. Okay, I said, okay, very nice idea. Two small problems to solve. A, how do we hyperactivate oncogenic signaling in cells that already have oncogenic driver mutations? Second, which of the many stress responses do we need to perturb to make these cells die when we hyperactivate oncogenic signaling? Right? So, small problems to solve, but not unsolvable. So, this combination of deliberate hyperactivation of oncogenic signaling combined with perturbation of the stress responses, we call a paradoxical intervention. Paradoxical because it's completely counterintuitive, it's not what you should be doing. But if you do what we should be doing, you always get the same answer. We get resistance by reactivation of the pathway, so that is a dead-end street. We cannot solve that problem. So how do we go about doing that? There is evidence that more is not better. I told you about the Goldilocks scenario. Here are two papers from Mariana Barbas's lab and from Harold Farnes that show that if you have an oncogenic KRAS mutation and an oncogenic EGFR mutation in the same cell in the lung epithelium, the animals will not get lung cancer. If you have one mutation, you get lung cancer. If you have two, not, because too much is too much of a good thing and it becomes non-tumorigenic. So here you see in practice that too much of a good thing is not a good thing, right? So there we go. So now we need to find a drug that hyperactivates oncogenic signaling. So I draw here for you the signaling of a promiscuous phosphatase in the cell called protein phosphatase type 2A, PP2A. PP2A inhibits MAC, inhibits beta-catenin Wnt signaling, and inhibits AKT signaling. This is why most pharmaceutical companies make what they call SMAPs, small molecule activators of PP2A, because if you activate PP2A, you inhibit MAC, you inhibit Wnt, and you inhibit AKT. That's good, right? For the conventional approach, namely to inhibit oncogenic signaling. But there is a small molecule inhibitor of PP2A called LB100, and if you were to inhibit PP2A, you activate MAC, activate beta-catenin Wnt, and activate AKT. Would these cells be stressed? I bet they would be, right? And this molecule has been developed, and it has interesting properties. And in fact, completely unexpected was when it was tested in a phase 1 clinical trial, the toxicity profile of that molecule was very moderate. So that made it for a very interesting proposition, right? So we started to test LB100 in a panel of colorectal cancer cells. Why colorectal cancers? I told you that Wnt activation is happening by LB100, MAP kinase activation, and PI3 kinase. These are three mutations that we see a lot in colorectal cancer. PI3 kinase, RAS, and APC loss, right? So if we give the cells an increasing concentration of LB100, rather than growing faster, they grow slower. That's the Goldilocks scenario. More is not better. And if we look at the Western plots, we see indeed that HC29, BRAF mutant, SW3, KRAS mutant, the phosphor ERK level goes up with LB100, phosphor June signaling goes up. We see that targets of Wnt beta-catenin signaling goes up. So we see indeed that there is more oncogenic signaling, but there's also more stress responses. DNA damage response, phosphor check-1, unfolded protein response. You see that many stress responses are activated, which probably explains why these cells grow slower rather than faster, right? As I said. So now we have a drug that does the first part. We have a drug that super activates the signals that are already activated by oncogenic mutations, but now we need to ask which of these many stress responses, and you see here just a few of them, are essential for these cells to be able to survive in the presence of hyperactivation of oncogenic signaling, right? How do we find those? And one way to do that is that Matthias made what he calls a stress-focused drug library, where he took 164 drugs that act either in DNA damage stress response, oxidative stress, mitotic stress, proteolytic stress, metabolic stress, and tested all 163 compounds in the presence of LB100 and in the absence, and asked, is there any drug that shifts the curve to the left, meaning that the cells become a lot more sensitive to LB100 in the presence of that stress-perturbing drug, right? And when he did that experiment in two different colorectal cancer cell lines, he found two families of small molecules, CHEK1 inhibitors and V1 inhibitors. So he was concerned that he was looking for under the light post for his lost keys, because he had only tested 163 compounds. So he also wanted to do an unbiased genome scale synthetic lethality screen, where he simply asked which genes, when inactivated by CRISPR, sensitize cells to LB100, because the guide RNAs disappear from the population in the presence of LB100, not in the absence of LB100, right? And there he found, again, that V1 was one of his outliers. V1 that was inhibited by the same target as a V1 inhibitor that scored in our small molecule. And then he knew that V1 was a good hit because it came out of the compound screen, it came out of the genetic screen, right? So we started working with a drug called adavosertib, a small molecule V1 inhibitor. And you see here a panel of colorectal cancer cell lines, and the story is rather consistent across the entire panel, which have a rather different genetic background, that while the V1 inhibitor is relatively inactive, the LB100 is relatively inactive. You see dramatic synergy when you combine these two drugs. And you see this also in short-term leukocyte cell proliferation assays, right? So it seems that adavosertib as a V1 inhibitor is really synthetically lethal with the EP2A inhibitor. If we do the Bliss scores, we get the same type of numbers that we saw before with the BRAF and the JR inhibitors, which turned out to be a clinical success. So we were very encouraged by that. But we wanted to, of course, also know, how does that work? Why is this synthetic lethality there? Right? So we now know that we inhibit EP2A, that MEK, Wnt, and AKT are up. And we know that V1 is a kinase that prevents cells from prematurely entering into mitosis. As long as the V1 kinase signals, the cells will not be able to go from S phase and G1 into mitosis. And that V1 inhibition facilitates the entry into mitosis once the cells have completed S phase. Right? So now we are filming with the lab of René, we are filming individual cells as they progress through the cell cycle. These are asynchronous cells, colorectal cancer cells. They spend on average 30 or 40 minutes in mitosis, and then they go into the next G1. Right? So the cells are asynchronous, so every cell spends about 40 minutes in mitosis in a 24-hour interval, and then goes on to the next G1. If we add LB100, we see that the cells, actually, many of the cells that enter mitosis never come out anymore. They remain stuck in mitosis. If we use adavosertib, the cells will enter prematurely in mitosis earlier. You see that the curve is shifted to the left compared to control. But more importantly, if we combine the two, the cells will enter early and never come out again. They are completely unable to leave mitosis, and we know why, because if you make karyotype of these cells, it looks like pulverized chromatin rather than neat, nice X-shaped chromosomes in the metaphase plate. So these cells have completely messed up their chromatin, and to make a long story short, I see there's only 4 minutes left of the shot clock. There is, these cells have severe DNA replication stress, and they enter into mitosis long before they have completed DNA replication. So they enter mitosis with 1.5 times their DNA instead of 2 times their DNA, and that cannot lead to a successful progression through mitosis because the chromatin is completely disorganized, and that leads to apoptotic death in mitosis. Now this was already known to a certain degree because the lab of Nick Turga had already shown that forced mitotic entry of S-phase cells as a therapeutic strategy used by inhibition of V1. Combination of V1 with chemotherapy is effective. There was a positive phase 2 trial in ovarian cancer. Platinum was adavosertib as a V1 inhibitor. Platinum comparing the replication stress, adavosertib allowing the premature entry into mitosis, and the combination is effective. So how effective is the combination that I showed you, namely here the LB100 plus adavosertib, here in black, compared to adavosertib with chemotherapy that was positive in the clinic, and LB100 with chemotherapy? And the answer is these are synergy scores, where the higher the synergy score, the better the drugs are in combination. You see that in all these cancer cell lines, these are 2 pancreatic, 2 cholangiocarcinoma, and 2 colorectal. In each of these 6 cell lines, the combination adavosertib plus V1 inhibition is far superior to adavosertib plus chemo or LB100 plus chemo. So we think we have a potent combination. The biggest worry, of course, of any potent combination is that this is in cell culture. You go to animals, and the animals will die on you, and that is a disaster. That, fortunately, turned out not be the case. Working with a Spanish collaborator, we performed orthotopic PDX models where we transplant human colorectal cancer samples into the colon of mice. We treat with one drug, another drug, or the combination. We see if you treat with the combination, then the only viable tumor cells are these little rims around these necrotic tissues. This is all inflamed stroma. There's hardly any tumor tissue left, even though there is some tumor volume left. Hardly any of that is taken up by viable cancer cells if you combine adavosertib with LB100. And there was no weight loss in those animals either. In a more conventional xenograft assay, where we put a cholangiocarcinoma PDX model under the skin of the mouse, you can see also, again, the strong synergy between the drugs without making. Right? So this works. And it could be something that we could try in the clinic. But how would you, if you were a cancer cell, become resistant to this therapy? Have you thought about it? Because you read the literature, and cancer cells, trust me, they read the literature too. They know exactly what to do, right? So if you inhibit BRAF, they activate KRAS because they know that's how you escape, right? They read nature better than we do. So if I were a cancer cell, I said to Mike Mateus, I would downregulate oncogenic signaling because then I would evade the stress and then I wouldn't have the problem anymore. Okay, Mateus said, let's put this to the acid test. How can cancer cells develop resistance to LB100? So here we do a screen where we add LB100, CRISPR screen, and ask which genes can modulate the sensitivity to LB100. How can we get increased sensitivity? How do we get resistance? So this is CRISPR-A screen. CRISPR-A is overexpression of genes to ask how do we get negative selection in the presence of LB100. That means which gene, when overexpressed, makes the cells more vulnerable to LB100. And look here, a whole list of oncogenes. MYC, we see here cyclin D1, we see components of Wnt signaling, ETS1. So these are all, if you overexpress oncogenes, then the cells become more vulnerable. Of course, because they get more stress, and more oncogenic signaling is more stress. Right? Conversely, which genes, when knocked out, make the cells resistant? There again we see oncogenes, and sometimes even the same oncogenes like B-cell line. Why? Because if you downregulate oncogenes, then you become resistant. So the CRISPR screen tells us that oncogenes are the most important determinant of the response to LB100. If you put them in all these hits, in a diagram you see one node around beta-catenin and one node around MYC. So that's of course academic. What happens if you give the cells a choice? So say, culture you, I'm going to skip this for the interest of time. We're going to culture cells for 6 months in the presence of adavosertib and LB100 until they become resistant. And then we ask, what have these cells now chosen? Not by CRISPR, but by spontaneous natural selection. How have they managed to become resistant to this combination? The first thing that you see is that they have lost their aneuploid phenotype. This is the phenotype of number of chromosomes of SW480 cells, around an average of 80 chromosomes, highly aneuploid. And that number has gone down to 50, nearly diploid, in the presence of the two-thirds. So the cells have normalized their karyotype. Why have they normalized their karyotype? Because they need to become more normal to escape the stress that comes from hyperactivation of oncogenic signaling. So is this normalization of their karyotype then associated with loss of oncogenic signaling? And the answer is yes. If you do single cell sequencing of cells that are either sensitive or resistant to this combination, we see that beta-catenin signaling is down in the resistant cells. MYC targets are down in the resistant cells. E2F targets are down in the resistant cells. And that is associated in the resistant cells with a loss of oncogenic signaling. Phospho-Jun is down. Axin and B-cell 9L are down as Wnt target. MYC is down. And as a result of that, the stress signaling is down. Phosphate signaling 3, checkpoint, gamma-2/8. Stresses are down, oncogenic signaling is down. But these cells still proliferate. Why do they proliferate? Because we give them a drug that tells them to proliferate. And if we now take that drug away, now what happens to them? Right? And the answer is, if you take the drug away, the cells can grow in 2D, but not in 3D. And 3D growth is the cheap man's mouse assay, telling us that these cells have lost oncogenic capacity. And when you test that, in fact, in an actual mouse model, we see that SW480 combination resistant are unable to form tumors. So to make a long story short, if you hyperactivate oncogenic signaling, you force the cells to give up their oncogenic phenotype, because that's the only way to evade the stress that is imposed by the hyperactivation. So we call this a paradoxical intervention, and this term comes from psychotherapy. I know this because my wife is in psychotherapy, and I opened one of her textbook and I found here in psychotherapy, paradoxical interventions are characterized by a deliberate reinforcement of the pathological behavior to improve the clinical condition. Such a counterintuitive approach can be considered when more conventional interventions fail. Now, have we done that? We have deliberately reinforced the pathological behavior for sure. We have upped the oncogenic signaling. And we have improved the clinical condition because we have forced the cells to give up their oncogenic phenotype. Now, can we try such an approach when more conventional intervention fails? The phase 1 trial will tell, and we hope to start that in the first quarter of next year. So on that note, I'll pose to you that I think that hyperactivation of oncogenic signaling is a viable cancer treatment strategy, especially because resistance selects for cells with reduced oncogenic phenotype. And on that note, Matthias is the hero of this story, and the work on that will be forwarded by Robin Janssen. And I thank you for your kind attention.
beautiful talk, beautiful biochemistry, kind of story, and I've been criticized before to call the cancer cell smart because it gives it human properties, but actually it is, isn't it? Because it
They have no other way than to react, right? I think they just do what we tell them to do, right? And that's a good thing. If you tell them to stop oncogenic signaling, they get it back. If you tell them to hyperactivate, then they will down-modulate. They look for that sweet spot where they can still grow.
so it's cellular intelligence, isn't it?
Well, it is in a way just steering evolution, right? It's steering evolution in the other direction rather than in the direction that you always steer it in, which is more anabolic, more oncogenic signaling, which is a losing pattern. We should be steering the other way.
I'm sure we'll have a lot of questions.
I have a first question. Sorry, Milena. I have a question. Thank you very much. This is something completely new. And with a simple approach, you manage two things. To kill cancer cells and to actually differentiate them to the normal phenotype.
Right.
Yes. Okay. So, but what is going to be with the normal cells if you stimulate oncogenic pathways with LB100?
Right. So that's a very good question. Is this going to cause more cancer than it cures? Right? To put it bluntly. And the answer is, I don't think so, for two reasons. The first reason is, it has been in a phase 1 clinical trial, and we did not see any new malignancies grow, at least not in the short term. And I would argue that if you are metastatic colorectal cancer, where we will initiate the trial, and your life expectancy is in the order of 2 months, that your first concern is not what might happen 10 years down the line. That's a sort of pragmatic answer to your question, but it's the reality of the day, right? But I'll give you a more scientific answer also. Normal cells don't have hyperactivation of oncogenic signaling from oncogenic driver mutations, and therefore the slight increase that we mediate by LB100 is not as toxic to normal cells as it is to cancer cells. And in fact, there are many people that take lithium chloride for bipolar disorder, which also happens to activate beta-catenin signaling because it inhibits GSK3 beta. And many people have thought that people that take lithium for bipolar disorder would be getting more cancer. The answer is epidemiological studies in people that have taken it for 10, 20 years show that they get less cancer. And that was supported by a beautiful experiment by my colleague in Amsterdam, Louis Vermeulen, who has these APC-min mice where you can inactivate the APC allele and then you get these adenomas in the colon. If you do this, you get on average 40 to 60 melanomas in the colon. If you do this in the presence of lithium, you get less adenomas in the colon rather than more. So even at this adenoma stage, more signaling is not better, but the adenoma needs a certain amount of Wnt signaling, not more is not leading to more. In fact, it leads to less because they cannot tolerate the higher level of Wnt signaling. Very interesting data.
I have a question. It's really inspiring. I have a question for the beginning. When you find check1, you couldn't find PKMYT at the same time. The PKMYT1 that has kind of a similar function.
Yeah.
Because you answered the question. If I was a cell line, I would express PKMYT1. That would be my answer when it comes to cells.
So there is a small molecule PKMYT1 inhibitor from a company called Repair Therapeutics. I've interacted with that company. They've given me their MIT1 inhibitor. We've tested it and it shows exactly the same phenotype with LB100. Very strong synthetic lethality with MIT1 as well. We don't know what is the better combination clinically. It depends what the toxicity is of the MIT1 compared to the V1 inhibitor. So we need to see. But in the preclinical models, the MIT1 inhibitor, which also prevents cells from entering into mitosis, right? Or stimulates, allows cells to enter mitosis, does exactly the same.
Thank you. It was a great talk. These bone cancer cells are addicted to high cycling. So did you see proteasomal subunits being upregulated, and did you try also any proteasomal inhibitors in combination with LB100?
We've done RNA-seq of cells treated with LB. You ask about LB100, right? And it's remarkable that the most downregulated genes are in the DNA damage response. That explains, I think, the synergy with chemotherapy that people have observed also preclinically. This is why this drug is primarily developed in combination with chemotherapy at this point in time. And we have seen that it stimulates interferon expression, inflammatory responses, most of which are likely to synergize with checkpoint immunotherapy. And in many preclinical models, people have shown that this LB100 molecule also synergizes with anti-PD-1 for that reason. So this is really a rather unusual molecule. It sensitizes to checkpoint therapy and it has these crazy effects on oncogenic signaling.
I have a question. So first of all, thank you for your talk. This was fascinating. And first of all, the thought behind it was fascinating. And my question regards the destiny of those cells. Are they stable when reprogrammed, actually?
Yeah.
And is it a cure or just a pause?
So I would predict that if you take the drug away and the cells would be given the chance to actually regain their oncogenic properties, they would, right? Because the cells are heterogeneous. You see that they're not all 46 chromosomes heterogeneous. The average chromosome number is down. So I would predict that the cells would actually gain oncogenic capacity over time and the parental population would come back.
So this is the drug that should supposed to be taken forever, right?
This drug should be given intermittently because the moment you give the drug, you select for the cells with the less oncogenic phenotype. If you then take the drug away, the majority of cells that are left in that tumor will not form tumors, but the rare cell that can still form a tumor will regrow, but can then be retreated to then select again for the downregulation of oncogenic phenotype. So what I'm most excited about is when we develop this phase 1 trial, what happens when the patients start to progress if we discontinue the drug? Will the tumors really stop growing? And what will the biopsy show us in terms of karyotype and oncogenic drive mutations? It'll be super exciting.
Thank you.